I've been trying for the last 10 minutes. अब जाके मिला. We'll let you in, Tarat. That I'd been trying for 10 minutes and finally got through now. It kept saying we'll let you in. Hi.
Hello.
Hello. The broadcast is on now. Ma'am, broadcast is on.
Fine. So should we start? Another 3 minutes to go and then we start.
Sure.
Rohit, I haven't been able to share your background, which you said.
So, ma'am, if you have that on desktop.
Yeah, I have it.
So, just go down, just see that logo of start video on your screen.
Yeah, it says stop video. Okay.
Yeah. There is a drop down there. Just click on that. Drop up.
It says FaceTime camera, same as system.
And choose virtual background. Yeah.
Huh?
Choose virtual background. There is another option.
It says FaceTime camera and same as system. I don't see virtual background.
Okay.
You are logged into a phone, ma'am, or a laptop?
This is a Mac.
Yeah. So Mac.
Under the FaceTime thing only, it's there. Choose virtual background.
FaceTime को choose करूँ पहले?
मैम उसके नीचे.
नहीं उसके नीचे है मैम.
उसके नीचे तो वही है. Same as system.
Okay.
So don't go inside the FaceTime.
Go to video setting. There is a option of video setting there.
Where?
बिल्कुल बॉटम है उसका FaceTime के नीचे ही.
FaceTime मेरे I have just two, FaceTime and same as system. What do I select?
I'm sending you a picture.
Difficult.
FaceTime HD camera, same as system. दो चीजें हैं मेरे पास.
Ma'am sent you the picture on
picture
phone.
on WhatsApp.
हाँ जी.
अच्छा. नहीं, see, I'll send you mine. Mine only has FaceTime and same as system. Okay, I'll send you mine.
So yours is maybe slightly different version.
Okay, can you see mine now? I've sent you what I have.
Hanji, yours is different. Fine, I will probably go without the backdrop.
Okay, done.
So it's 5 o'clock.
Same as system कर दूँ?
मैम करके देख लेते हैं.
Same as system भी कर दिया मैंने, कोई फर्क नहीं पड़ा वैसे ही. It's the same. Must be something in the setting.
Should we start, ma'am?
Yeah, I suppose. Sir आ गए, logged in, Dr. Pandav?
हाँ sir is logged on.
Like a minute back.
How do I get to see more people together? मेरे को सिर्फ फैजल दिख रहा है.
Ma'am, just go to participant. Then I think the top part of the screen you could see the pupils are already logged in.
No, that I can see, but I was wondering if I could see more people.
Then
Ma'am,
you scroll it in sideways.
Yeah, ma'am. Hello.
Hello, yeah, Rohit, I can hear you. I can't see you.
So, ma'am, there is a option here down, participants. So, if you click on
Okay.
that, so there you can
Okay.
see attendees and panelists.
Yeah, I can see them, but I can't see them in the sense of video. I can only see the.
Yeah, everybody has, ma'am, switched off their video, so that is why.
All right. There's no gallery view or something. I was just asking.
So there is, ma'am, on the top right side, speaker view and gallery.
My Zoom seems to be a little weird today. Seem to see anything. I don't know.
Dr. Pandav is, ma'am, trying to log in because of some
Okay.
internet issue.
Okay.
Okay.
Because I can only see Faisal and myself. Yeah.
You are in full screen or?
I can be in full screen. It's not making any difference. Now it's full screen.
Then on the right side of your screen, I think the people will already, those who are already
No.
logged in.
सिर्फ मैं हूँ. मैं हूँ और तुम हो.
I think we have already 28 participants right now.
Rohit, can I share the screen and just check
That
it?
includes 13 of us.
Sure, ma'am.
Yeah.
Actually, attendees are
That's the
also
fact.
joined.
Oh, everybody's joined. Okay. I've been trying since 4:40. It just kept saying. And suddenly when you talk to me, it worked. So I don't know.
So yeah, you can, ma'am, try that share screen. So this is
Okay. Host disabled attendance. Host disabled attendee screen sharing. Okay, I'm an attendee. That's why.
No.
Yeah. I get a message saying host disabled attendee screen sharing.
But you have logged in through a panelist or attendee, ma'am?
I have logged in whatever mail you've sent me. I have no idea what I am.
I think you must have received 2 mails. One is directly linked. You need not to register. Just join the link.
I just joined the link.
You didn't register anything
No.
or anything.
No. I wrote my name, Sushmita.
No, the different mail.
The link is there, which automatically takes up your name.
Which is that? I did the one. Okay, I'll leave and come back.
Yeah.
No, ma'am.
Mr. Rohit, you can send the link to ma'am again.
Rohit, you sent me one in the morning. You sent me another one just now. I just logged the latest.
I'm again sending. Anyhow, ma'am, you are showing in panelist only. Even to me, it is in panelist. That is how you're able to see.
But when I say share screen, it says the host has disabled attendee screen sharing.
Okay.
Just 1 second, ma'am. I am sending.
Yeah. So it says disable share. I think I should log out and you send it again.
Gaurav, are you somewhere around Pandav, sir?
Gaurav is in the department only, I think.
Yes, I'll just go and check it out.
Yeah, because sir is not logged in and it's 5:05. So I was just wondering whether I should.
Yes, there was just here only. I'll just go and check it out.
Please,
just
thank you.
PJ ka net broke. Actually, ma'am, there is some network issue in PJ network issues.
Okay.
Oh, I think I put an.
Yeah, sir is back.
Yeah.
All right, I'm back online. Sorry, my internet is going off actually.
Sir, everyone was asking for you on the forum, so
नेट बंद हो गया मेरा. आपका चल रहा है?
हाँ सर, I have hotspot. मैं या तो hotspot on कर देता हूँ.
एक मिनट आ जरा.
You can connect with mine.
हेलो. यार कुछ करना पड़ेगा. सबसे चल रहा है इसका. नहीं चल रहा. There's a problem. I just close it. Can't, yeah, इसमें था ना link.
हाँ जी सर.
ये कौन सी दूसरी आ गई?
सर यस कर देते हैं प्लीज.
ठीक है, जियो है ना?
सर मेरा भी कनेक्ट नहीं हो, मेरा तो सर एयरटेल है.
हाँ बस मेरे एयरटेल से चल ही नहीं रहा.
मैं तो उधर भी इसी से चला रहा था.
Computer audio. Okay, can you see me now?
Yes.
Okay, thank God. My internet is, I think, is going off and on. So I don't know how long it's going to last. There's some problem with PGI internet. I hope it stays now. All right, ठीक है, अभी तो इधर ही है. तो आप ready रख लेना in case it goes off, अपना उसके साथ connect करना. ठीक है. All right, so we are ready to go. I'm sorry for delaying everybody.
So Sushmita ma'am also had a glitch when she was joining, so she's trying to rejoin. Should we wait for her before we start?
Oh, Dr. Sushmita?
Yes, sir.
Some glitch.
She's around somewhere, right?
She was home, but she's trying to join in. There was some glitch when she joined earlier.
Does she have difficulty in joining in?
A little, maybe.
Hello. Good evening. Here हम लोग ना मीटिंग में हैं actually, and अभी चला ये, हाँ अभी चला, but make sure that it works for next 1.5 hours.
Hello.
Yes.
Just don't fiddle with the system. Don't.
No, it's I still
around somewhere.
I still
Okay,
can't.
just monitor it. Huh? All right. Okay. Thank you.
Okay.
I think we can continue.
Okay.
All right. So she can join us because she has a little towards the end of. I mean, her talk is the third one. So.
No, I can't share screen now. It still says
She had joined, but she could not share.
Yeah, she can hear us now.
Disabled attendee screen sharing. So what is the point then?
So she has time to sort out things basically.
So should I log out?
Okay, good evening, everybody. And we are here to join us and share our ideas on glaucoma practice management in these challenging times of coronavirus. It's going to be an interactive session on glaucoma practice during these tough times, and to change the way we have been practicing ophthalmology to adapt to this new normal. We will be having a few interactive talks with Professor Pandav and Professor Sushmita Kaushik from the Department of Ophthalmology, PGI, Chandigarh. And with this initial backdrop, I would like to invite Professor Pandav, who is the head of glaucoma services at Advanced Eye Center, PGI, to welcome all of you and to set the ball in motion. Professor Pandav.
Thank you, Parul, for a brief introduction of the program. And I think we have been actually thinking about a meeting, especially for the glaucoma sport group, but because it's an online meeting, so it can actually have a wider reach. So that's a good thing. We couldn't do this meeting in the March when we had planned one, but because of the lockdown and curfew, things have changed a lot during that time, and now I think it's a very appropriate time. So we get together and discuss about the how we can manage glaucoma in the current times. So I welcome you, all of you.
I did that. Let me see if I can share.
Sushmita is back online. Good to see.
No,
Sushmita,
but I still can't share. Let me tell you.
And we had Dr. Guru Satinder here, Rajiv Tuli, Rohit Kumar. I can't see him. Maybe he isn't logged in yet. Ujjwala is already there. And Sunil Agarwal, I think he's online already. Faisal and Srishti. They are my colleagues from PGI. So I thank you all to agree to be the panelists and participate in this program, and all the audience actually who are there listening to us. Thank you all joining us for this program. And with this brief intro, I'll request Dr. Parul to go ahead with the talk because this is a very different situation because suddenly we are in the middle of a pandemic, and it's very important to know, the dynamics of pandemic and how it is affecting us as an ophthalmologist. So Dr. Parul is, I think, going to highlight some of those issues.
So can you see my screen? Can you see the slides?
Not yet. You have to share the screen.
I did that.
And you have to.
It says the host has disabled attendee screen sharing.
Sadiq disabled.
Yeah. Rohit, you have to do.
Yeah. Ma'am, try it now.
1 second. Can't. Can you see it now?
I can see you, Srishti, now.
Rohit, can you see it now?
No, not yet.
No, ma'am.
You have again tabled it, ma'am.
I have done whatever you told me to do. Okay, let's see. Now, yes?
Yeah, yes.
Great. Excellent.
Right. So I'm sorry, everybody, for the technical glitches. So let me begin just a brief perspective from an ophthalmologist's point of view and how corona, just a very, very small virus, has changed our entire world and the way we practice. Before I begin, I would like to pay a tribute to the ophthalmologist who was a hero and a whistleblower, and he was the first doctor to report COVID in China. And unfortunately, he contracted the virus from an asymptomatic glaucoma patient. This just brought into the fact that a young, healthy ophthalmologist got disease from a young, healthy patient. So this needs to be taken seriously because there have been several reports of several ophthalmologists who got infected and who even died treating COVID or seeing patients during this pandemic period, despite being fully gowned with a protective suit and an N95 respirator. A very recent study, which was just published a couple of days back in Journal of Hospital Infection, showed that COVID-19 can spread across nearly half of a ward with a single droplet of infection of the virus on a bed railing within a period of 10 hours, and the virus can persist in that half of the ward for up to 5 days, according to a simulation study. So this is something which we need to take seriously. Having said that, we can't be sitting at our homes forever because we have a gamut of conditions like severe diabetic retinopathy, wet AMD, ROP, ocular trauma, all these that force us to get out and take care of patients who really need our services. So we need to stratify our system and develop a triage to see which patients need our emergent care, which patients would need to be seen urgently, and which patients can be deferred. Subspecialty-wise list of the triage pattern has been published in the consensus statement given by the AIOS, and that can be that should be referred to for you to formulate this triage pattern in your services. Another change that we are going to see is that our conversation time and our time for examination needs to be really cut down to about good 8 to 10 minutes only, so as for our own safety as well as the safety of the patient. With reopening of ophthalmic practices in some places in India and in the days to come in certain other places, depending upon the situation in that area, we need to develop a new normal, which has been rightly denoted by the mnemonic coronavirus itself, where C stands for consent from all the patients and cutting down unnecessary expenses. O stands for outlining a proper plan. Each of us has to draft a standard operating protocol for our own setup so that there is no lack in our seeing patients. We need to over-communicate with our staff and with our patients to re-emphasize the importance of following all sorts of precautions in COVID times. We need to review our finances, take care of the outstanding bills, say a big no to buying costly equipments and to any expansion plans till the time the current times are over. We need to arrange all the necessary items to stop or limit the COVID transmission, virtual consultation, telehealth, which would be covered in detail by Professor Pandav, a good inventory management, to review the situation every day. The guidelines that have been given to us by AOS or by other bodies are guidelines for today. Since we are learning each day about the virus, the guidelines are going to be changing, and hence we need to review and revise. We need to update ourselves every day and ensure whatever we have formulated for ourselves is followed in practice. We need to manage our staff, practice social distancing, and use proper sanitization at all times. So this is how we are going to step into our ophthalmic practices after the corona lets us do the same. We have our new best friends in the form of a N95 mask or the PPE. Now, how to use the PPE wisely by us is something which really needs to be looked at again very cautiously. And that depends upon the COVID-19 status of the patients that we are going to see, on the risk of sight-threatening entity which the patient has, and whether we are going to have a brief contact with them, as in just examining in the OPD, or a prolonged contact while we are doing a procedure on them or doing a surgery on them. And also whether the procedure that we are carrying on at the patient is aerosol generating procedure. So depending upon that, the kind of PPE that we would be requiring is again given to us by the guidelines which have been cited by the IJO. We are using all sorts of masks, but it's a good idea to understand which mask we are using and whether it is actually effective. So we have two types of masks, N95 and KN95, that most of us are using when we are seeing our patients. Essentially, material-wise, N95 and KN95 are the same, but N95 has a snug fitting. So whenever we are using a KN95 or any other mask, we need to ensure that it is snugly fitted at the nose and there is no sort of leakage from the sides and from the nose. The masks are actually supposed just to be disposable, but since we have a shortage of N95 can be used 4 times, but after each use, it needs to have a break period of 72 hours. So you need to have 4 masks and that can tide over a period of good 16 days if you take good care of them and sterilize them. Non-valve masks, which many people are wearing these days, are not good, and especially for people working in hospitals and medical practices, because they filter out the air for you, but whatever you are exhaling is not sterilized. So they are not recommended for hospitals and medical practices. And we have to be using all our PPE and N95 masks very cautiously. So in cases where you feel that there is a shortage, elastomeric half mask respirators, which can be cleaned again, can also serve as a good alternative to the disposable masks. Resource stewardship cannot be more emphasized in these tough times. The entire world is using all sorts of PPE at the same time. And with the increasing load in the hospitals, we have to conserve our resources. Having said that, it is up to you to draft a policy in your department or in your setup to see whether the 3-ply medical masks would be good enough for certain activities at your center, or you really need to wear an N95. Because some studies have shown that they almost have a comparable effectivity when used for a viral influenza-like outbreak. So probably for certain activities and for certain staff and personnel at your center, you need to use these resources widely. Having said that, I would like to re-emphasize that all these resources alone are not going to be helpful. Along with physical distancing and a good eye protection, which is must for all sorts of eye care professionals, still there are some chances that we can be prone to getting a corona infection. So using all them judiciously is must. At most places now, temperature screening is being done to let the patients in at the hospital or in any medical setup. Is that an eye wash, or is it something which is actually foolproof? One really needs to remember at this time is that the rate of viral shedding and infection from pre-symptomatic individuals is very significant. An individual who becomes symptomatic, febrile, or develops a cough starts shedding the virus 2 to 3 days prior to the onset of the symptoms. So that's something we really need to take care of. And the slit lamp shields that we all have put up in front of our slit lamps, we need to remember that a virus lives on plastic for about 5 days. So after each patient, we need to clean these shields from both the sides, and should not be lax about this cleaning activity. So the initial studies from Wuhan showed that patients with conjunctivitis, they had COVID infection. And a recent study from South India also found out that 1 in 45 patients with COVID-19 had a virus in the conjunctival secretions despite any conjunctival inflammation. So since conjunctival cul-de-sac is prone to anyway having outside pathogens, it's a good nesting point for coronavirus. So we really need to take care of ourselves when we see patients with conjunctivitis, because the virus can replicate or survive in the conjunctiva even up to 3 weeks after signs of conjunctivitis disappear. So wearing an eye protection, eye protective goggles, and a face visor are of utmost importance for an ophthalmologist. The rampant use of sanitizer has brought about another entity, which is the sanitizer aerosol-driven ocular surface disease. And that's something which is now becoming much more pronounced in closed environments. So this is nothing but a sort of a toxic or allergic conjunctivitis. And the alcohol in the sanitizer leads to a desiccation of conjunctival goblet cells. So we need to tell the patient to keep the sanitizer bottle below the eye level during usage, and to have an open and a ventilated room when we are using the sanitizer. This is going to bring about a lot of challenges for our glaucoma practice, because for screening, a lot of us depended upon a non-contact tonometer, but we know that using a non-contact tonometer would lead to aerosolization, so that's absolutely out of the picture. And repeated use of Goldman applanation tonometer would mean sterilizing the tono tip after each use and letting it air dry before it is good for use for the second patient. TonoPen comes as another tool, handy tool in this scenario, but then we would have to be taking care of the disposable tips. So a lot needs to change. You would need to titrate which patient of yours can actually do without getting their pressures checked. The OCT would prevail over the visual field for some time, because the disinfection protocol for the bowl of a Humphrey perimeter is not really very clearly delineated, and using a lot of disinfectant can damage the bowl and the optics of the perimeter. So for some time, the diagnosis will be based upon the OCT, but here again, over a period of time, we don't know how long the virus lasts. We will have to question our decisions, because we would be ignoring the structure versus the function paradigm. Will we treat more ocular hypertensives in absence of visual fields? Will we treat the red green disease? Another change that would appear would be in our retinal practices, because there is now it is being said that home dilation should be preferred. You don't want your patient sitting in the waiting area for an hour to be dilated. We need to prioritize the monocular patients. FFA and ICG would be avoided. And again, a lot of diagnostic decisions would be depending on the OCT and the OCT angiography. Procedures would change. Again, the surgical protocols will change more in favor of things which are faster to do and require lesser tissue contact. There would be a new normal in our OTs. We would be avoiding direct contact with microscope, operating with plastic draped around the microscope to prevent aerosol spray, double masks, and we would be working without an AC and working in scenarios which would maximize air changes. The COVID patients would be operated entirely in separate OTs, and those who have recovered from COVID and require an ophthalmic surgery would really need to have 2 negative PCR tests, or they will need to wait for about 6 weeks from the onset of their symptoms to be eligible for surgery by an ophthalmologist. Extreme caution to be exercised when we are getting our patients operated under GA, because most of the procedures that require GA are aerosol generating ones. So the ophthalmologist should enter the OT only after the anesthetist has done the intubation, and then only they should start. At this time point, patient education is important more than ever. We really need to emphasize our patient to reduce the direct touching of eyes and face, to refrain from wearing contact lenses, switch to wearing glasses. We can educate them about home monitoring devices, though it will take some time for India to switch from the practices that we have been following since ages to practices like, say, for example, doing a tablet perimetry rather than going in for a full-fledged visual field test on an Humphrey perimeter. There are places in US which now people of wet AMD have an OCT device at their own home, which can give a good idea to the consultant of seeing these patients. Then we have several apps which can also help the patient to monitor. So at this time, what is expected from us is to maintain a balance between the maximum possible ophthalmic treatment which we can provide to the needy patients while maintaining minimal risk of transmission of the virus. We need to take into consideration the extent of available resources nationally and to use the available resources in as wise a way as possible and to innovate. Now, down there, we have some images from the Aravind Eye Hospital, Pondicherry, and they have beautifully innovated the use of a 90D and a 20D using 3D plastic rims, which are covered by a cling film to prevent repeated deposition of virus particles on the lenses, UV sterilization of the masks, and chamber separation to keep the doctor and the patient at a decent risk. We need to keep abreast with the scenario and keep modifying the consensus to suit all situations. And for that, we need reliable sources, which are enlisted here from WHO, ICMR, the CDC, and the American Academy of Ophthalmologists, and the AIOS. We need to remember that we are still learning, and we would be learning for many, many, many more days to come. So we need to follow all these practices, keep revising them, and probably have a mock drill at our own center, formulate our own operating protocol so that we are safe and we keep our patients safe. So thank you very much. The questions can be dropped and we can discuss the questions after Professor Pandav's talk, which would be realigning ophthalmic practice to COVID norms and role of remote consultation. So we can take up the questions for this talk after Professor Pandav's talk.
You'll have to unshare your presentation, yes, unshare your slides, and then so that I can load mine.
Done, sir?
Okay, I can still see your slide.
Just stop. Yeah.
Okay, so, okay, great. So I have changed my laptop actually in between, so I'll have to start my presentation again.
So meanwhile, if there are any questions.
Yeah, if there are any questions, I think please, yeah, take those.
Dr. Modgil has asked us what method to use to sterilize applanation tonometer. So the applanation tip can be sterilized with an alcohol wipe and let it air dry. But if we are using alcohol wipes a lot, then in that case, the glue which is holding the two prisms can get loosened up. So making a 2% glutaraldehyde solution is a good idea. The glutaraldehyde solution which we make once lasts for good 14 days. So you can have a small aerosol bottle filled with the solution by the side of your slit lamp, and that can be used to sterilize the tonometer tips, the lenses that you use, and the surface of the slit lamp. I hope that answers your question, Dr. Modgil. So are you ready?
Just a sec, I am. Yeah, I think so. Just a sec.
There's another question by Dr. Bashyal, and he says that what kind of plastic can be used to cover the 90D or 20D lenses so that the examination quality is not disturbed. So what the Arvind people have done is that they've got a 3D printed case around the lenses, and over that they have put a cling film that we use in the kitchen. But if you don't have the facility of getting a 3D case, then you can try pulling a cling film on them, and after each use, just remove the cling film, clean the lens, and change another cling film. So that should help. We've tried doing that on the lenses of our OCT machine and the biometry equipment too. Professor Pandav is online, and I would request Sir to now enlighten us with his presentation on realigning ophthalmic practice to COVID norms, and he would be talking about the role of remote consultations in this scenario.
Okay, thank you, Parul. Can you see my slides now?
Yeah. Yes, sir.
And can you hear me also?
Yes.
Excellent. So I have changed the laptop now. Thanks to Gaurav. I think he has lent me his internet connection. So basically, I'll be talking about a realigning ophthalmic practice to COVID norms and role of remote consultations. Now, something about corona pandemic is that things are changing fast. So what is information is there today? It might change, but I think last couple of months we have learned a lot, and that's what we are going to share. I have no financial interest in any of the products, procedure, or any names I mentioned during my presentation. In a pandemic, it's important to understand how you get an infection, because whatever you plan for your patients and for your practice, you have to know some basics about this. The corona comes from is a person-to-person contact, and whether will you get infection or not, that depends on the exposure. So how much the exposure the patient gets, and the exposure is equivalent to basically the amount of virus that is shed into the environment and the amount of time you spend in that same environment. So it's a time and the dose, both are important. Now, persons who are infected with this virus, they shed it, through the normal breathing as well, but the dose is less. But when you are talking, you shed almost 10 to 20 times more than normal breathing. And if you are shouting or coughing, and then there's a lot more, like 1,000 times. And when you are sneezing, you are basically creating a kind of a mini storm around you and throwing particles everywhere. So you had to be, so that means in a clinic, you don't shout much, speak much, the minimum of that kind of interaction would help you maintain a low virus load in the environment. Another thing you have to understand is that what is the role of the hospitals in the pandemic? The main role is to prevent mortality. You treat sick people so that they recover fast and they recover easily and reduce the number of deaths. Hospitals per se do not cure the epidemic. The epidemic or endemic is actually a community disease, and it has to be treated in the community. So all the measures which we have been doing last couple of months, they basically aimed at community. Of course, there would be sick people and they have to go to the hospital. So hospitals have a role to play, but the major thrust has to be in the community, and that we all have to propagate and people have to understand. And when the pandemic happens, the treatment of other ailments takes a backseat. So people will get sick of other reasons, for heart problems, liver, gut, eye problems, glaucoma, one of them. But they kind of tend to take a little backseat, and some of these patients would, deteriorate during this period. So we have to be mindful of that. But having said that, they say in pandemic, there's only one emergency, and that's pandemic. But when is the height of the pandemic? That's probably true. But when the pandemic is kind of a little is still building up or is waning away, we have to take care of other patients as well. So coming forward to glaucoma, which is our area of focus today, we know it's a blinding disease, but we also know that it gives us time. So most of the patients do not go blind because of glaucoma overnight or in a month or time. It takes several years, actually several months, if not years, for significant deterioration to happen. So that's good. That gives us time during this period to tide over. But there would be some cases who can deteriorate fast, like you have an acute rise in pressure angle closure or secondary glaucoma. Now, those are the patients who are kind of an emergency and we need to take care of those patients. And also if you have a patient who is uncontrolled and is progressing faster, so we need to keep that in mind that by the time the pandemic is over, the patient might lose significant vision. So we need to think about those patients as well. The question is who should you visit you in the clinic? Because we want to maintain social distancing and we want to keep people away from the hospital as far as possible. So you have to prioritize. So as I said earlier, the acute rise in IOP, whether primary or secondary, would warrant a hospital treatment and hospital visit. If there's a poorly controlled patient who is losing vision, we need to take care of him. If the advanced glaucoma is there, even if it's well controlled, advanced glaucoma, they tend to progress, and so we need to monitor them a little more frequently. So this is kind of the list of the prioritization that one can do. If the patient is stable, best to defer that patient, even if he has to wait for his investigation a little more time, that should be all right. And you have an elderly patient, high risk with other comorbidities, keep those patients preferably at home rather than calling to the hospital, unless that belongs to category 1 or 2, as mentioned above. So as you can see, the focus is already shifted. Because of the corona pandemic, our focus from early diagnosis and treatment is gone to basically to identify patients who are at risk and who cannot wait. So emergencies and high risk of loss of vision. So currently we are focusing on those patients rather than on early diagnosis and treatment, because diagnosis and treatment can wait for a couple of months, and hopefully by the time the corona situation will improve, and we can get back to these patients and do whatever we can help them. So it's very important to prevent the spread of the virus, because if we don't do it, the hospital themselves can become part of the problem instead of part of a solution by becoming the hotspots for spread of infection. So thereby it's very important that we take care of the patient and we also take care of the staff. So the patient and staff safety is very important in a hospital setting, and that we must always be mindful of whenever we are programming, doing these programs. So the triage is very important for this reason. And before the patient comes to a hospital, if the patient is already in the hospital, then we have to have mechanisms there where the social distancing is maintained and you have some way to deal with patients who have already come. But best would be to triage them at home before they even come to the patient. And there might be some problems, issues which can be sorted out just by telephone or some other telecommunication device. And that's where the remote consultation actually comes in very handy. This is very useful for glaucoma patients or all those chronic diseases patient and patients particularly who are already on treatment or on continued long follow-up. So the idea is to assess the need for a hospital visit. So on a teleconsultation, you could assess whether the patient really need to come to hospital, or he can wait for some more time or some more months. And also you will be able to solve some of the patient's problem remotely. Most of these patients, the problems would be, the smaller ones. They will be worried about the missed appointments. They will be running out of the drugs. The drug is not available. The drug they are using may not be available because of the lockdown. So they have to use some alternative of that. Sometimes may have new symptoms or allergies or redness in the eyes. They may be worried about their tests, which are, which couldn't be done during this period. And sometimes because just for the moral support, but they have been used to visiting you periodically every 6 months. And if they don't visit you, they don't feel comfortable. So talking to the patient itself is is helpful, is therapeutic in many times. And that can be very easily done from a remote situation. So the remote consultation could be done in many ways. So I'm going to look at the different methods that we can use for remote consultation. But the principle is the simpler is the better. So if you have something which is very simple, which can be implemented easily and by most people, that would be the best way to begin with. So the telephone is something which is everyone has, and many of us have smartphone these days. What you have to do basically is to publish the phone numbers with instructions. And once you do that, the patients can call those numbers and talk to you. One more important thing that goes with this is you have to develop a mechanism to deal with the numbers. So someone has to be there to receive the calls from the patients who would be calling back to you. So the telephone consultation can be done remotely, and there are kind of 3 models which will work for the consultation, for telephone-based consultation. The one is a direct call to a consultant. So the patient has your phone number and he can directly call you. So it's good for the patient, easy access, and problems can be sorted out quickly. If the patient is new, then they can be guided, but there might be a little difficulty there. The downside is that you need the doctor to be available, to receive those calls, and doctor's time may not be available, or there may be shortage of doctors. Other thing is the doctor may not have all the data available to him to reply to his answers on the spot. If it's an old patient, if you remember him, that's okay, but sometimes it's not kind of possible to remember everything about the patient. So their disadvantage would be there. Another issue would be the patient identification on phone consultations, basically, because anyone can say that, okay, I'm so-and-so calling. So you have to be mindful that you try to verify the identity of the patient that you are talking to. The second model is a call-through model, where the staff receives the call, and the trained staff would, try to solve the patient's problem. It's a smaller issue like the drug is not available, or the appointment rescheduling or test rescheduling. Those things can be handled at that level. But if required, he can connect the patient to a consultant, and then the proper consultation can be done. Now that would save doctors time, and patient also gets more information that way. The important thing here is that the downside would be that you need to train your staff to handle telephone calls, and they need to be trained in how to decide and which call is to be put through and which is not to be put through. The third thing that we are following is the callback model. Now here the staff receives the call and he notes down the number as well as the reason for the call. And then the list is given to the doctor, and then doctors can prioritize the call back. So if they think that some patient really needs more urgent, so they can be spend more time with them. The calls which are less urgent, you can spend less time with those calls. Another good thing with this model is that the medical record, if it's an old patient, then you can fetch the medical record of the patient and go through his history before you call that patient. So that way, the quality and the usefulness of the interaction will be much better, and it will be more beneficial to the patients. The downside would be that the patient has to wait for his turn, and sometimes he might have to wait several hours before he gets the call back. So this is the model we are doing these days, and I hope this video plays. So this is the Advanced Eye Center, and you can see when people are receiving, they are calling back now. They have the list of the people who have requested consultations, and they have to maintain social distance. If we have the records online, so we can check records online, or we can get the patient's files from the CRD. The doctor will go through the patient file and on phone, and they will write down the consultation on the card, and then this photocopy of this card can be transmitted to the patient as a prescription. So that working well with us so far. And most people are using smartphone these days, so it's better because then you can transmit the text as well as images through that. And if you want to see any past reports, you can request the patient to send them over mobile phone, and you can also look at the images if the pathology is such that, if you have a lid tumor or you have hemorrhage in the conjunctival hemorrhage, redness in the eye. So you can always the patient to send a photograph, and you can have a look at that and then call back. There are less chances in error in prescription. So if the text is transmitted, then if you're telling prescription on phone, then there are chances that there could be spelling errors or errors in understanding. So that also is useful, and it also keeps a record of what you are giving or what the transaction is happening between you and the patients. Another thing which is coming up is the web-based platforms now, and the access through PC or mobile apps is possible. The problem is that there are a number of apps are there actually, but when you are using these apps, they are third-party applications. And the data security and confidentiality of the patient is a major concern, because you don't want to give your patient's data to a third party. And so there are kind of apprehensions with these platforms. And also you need a good internet connection for this system to work. One of the products which is coming up now is the eSanjeevani OPD for general practice. Now this is actually, I'm mentioning particularly because this is a Government of India initiative. So this platform is created by Ministry of Health and Family Welfare. And this is already in use for general practice in many states. This is nice software. We have seen it a few times. So this is kind of a video conferencing based system where audio, video, and text-based interactions are possible. Patient can upload a request, previous requests, photographs. You can request patient to upload more reports if you want. And also you can write a prescription to the patient online and then transmit it to the patient. So the prescription patient can print it and use it as a regular prescription, and which is applicable and which is accepted. So this is a platform which is available for general practice. So this is kind of roughly how it looks like. Now, this is not for available for specialty training, but we are working with the CDAC. This is developed by CDAC, which is a government department. So we are working with CDAC, and now actually I am helping CDAC to develop a eSanjeevani OPD for ophthalmology. And so where we are trying to match even at the subspecialty level, like someone wants a glaucoma consultation, then he will refer to a glaucoma matched with a glaucoma specialist in PGI or whichever hospital is participating, and same is for retina, oculoplastics, cornea, and other specialties. So this is coming up. Actually, I've been waiting for a permission from PGI to implement it in Eye Center as a pilot project, and today only I got the permission. So within a few weeks, I think we should have something to, we might be ready to roll this for test purposes. Now, all these remote consultation basically comes in the domain of telemedicine, cornea, and other specialties. And another, this is an enabler basically of healthcare access and affordability. So we know that the world over, actually there's a shortage of healthcare professionals. So the access to healthcare is not easy. And also it is costly in most of the countries, but it's especially true for India, where we have a significant population under poverty line, and we have a lot of village populations, and sometimes some of them are very difficult to access. So that telemedicine has a role, especially during these times, to play. Now, traditionally, the telemedicine is like you needed a big setup. You need a telemedicine setup at both the ends, at the doctor's end as well as the patient's end, and you have dedicated lines. So most of the time, the interaction is like doctor-doctor interaction or a doctor and healthcare worker interaction. But this is kind of changing now with the availability of the fast connections, with the broadband connection in different, even in the remote locations. This is kind of changing. So the dependence on a dedicated hardware is reducing, and that way is going to help a lot. So this leads to better doctor-patient interaction, and because this is an audio video, so no verbal clues and other can also be gained like you do that in a normal. Now, since there's a lot of happening in the digital area, in the telemedicine, remote consultations, very soon it could lead to some kind of a chaos. So the government of India has already come up with telemedicine guidelines, and these guidelines basically enable registered medical practitioners to provide healthcare using telemedicine. And this document gives you the definitions: what is telemedicine, what is telehealth, who is an RMP, what are the requirements to practice telemedicine. So all that is very well defined in this document. I will give you the reference towards the end. But the key essential element, even in telemedicine, is the professional judgment of the doctor or the registered medical practitioner, because that judgment has to be made like you do in the clinical now, and has to be, it has to accompany with all the moral and ethical issues that are there with the medical practice. So all that has to be. So thereby, the key personnel still is the the RMP, who plays a very crucial role. So this committee has actually decided, has kind of there are 7 elements to be considered when you are doing telemedicine. So number 1 is the context in which the consultation is done. Then you have the identification of the RMP and the patient is important. The mode of communication is important. The consent of the patient to participate in that process is important. Then type of the consultation, the patient evaluation, and finally, it has to have a component to the patient management as well. So I'll just take you through quickly. So what it means is the context basically is that it has to be in a proper context. Now, if patient calls you and if he says there's a acute cardiac emergency, then obviously telemedicine is not going to work there. So the patient has to be told immediately that, look, this is not the right platform for you, and you have to go back to a hospital, near a hospital, for a physical contact. But on the other hand, if this problem is something which can be sorted on telephone or video consultation or on a text-based system, so that can be handled. So there also the choice of appropriate medium would be very important. So it has to be contextually relevant, so telemedicine. The second thing would be that identification is very important, because teleconsultation cannot happen in an anonymous way. So you have to know the patient, you have to identify the patient, that who are you giving consultation to, and also the patient has to know that who is talking to or who is consulting with. So this has to be very transparent, and some kind of a record has to be maintained on this as well. As the mode of communication, as I mentioned earlier, this has to be an appropriate mode of consultation. So if it's just a mode of guidance, like somebody has missed a dose or a drug is not available, one can probably do just based on the telephone system. But if you want to have a visual view of the lesion, or you want to see all report or photograph, then obviously the audio alone is not going to work. You need an audio video with that. And ideally you should have audio, video, and text, all those things based in the system, so that they kind of complement each other and give you a more meaningful experience to the patient as well as to the doctor. The consent for consultation is again very important. Most of the time it consists implied, so that means you don't actually take it explicitly. And like you see patients in the OPD, but the patient has come to you to the OPD and with the intention of getting examined. So the consent is implied. So that way, the same way, if the patient is calling you from his phone, and so that means he's wanting consultation. But if on the other hand, if patient is not calling and you are contacting the patient, or someone on your behalf is contacting the patient, that means in that situation, you have to take a consultant from the patient on the telemedicine system itself. So your consultation should begin like that. We are so and so, and we are talking to you regarding your this health issue, and are you okay with the proceeding with this process or not? And if you're not willing, then you can disconnect the call now or anytime. So you have to give the freedom to the patients to choose whether he want to go ahead with the consultation and whether he want to continue or he want to stop it. So that has to be there, and it should be documented. The other important thing is the information exchange. So whenever you're talking to the patient, a meaningful exchange of the relevant data has to happen. It's not a social interaction. So it has to be professional interaction. And the RMP who is doing the teleconsultation must make sure that he gathers sufficient information which is useful for taking a professional judgment. And only then he has to go to the second step of advising or prescribing. If he's not satisfied, he can always tell, look, I need more information. I'm not getting to the point where I can prescribe or advise you. You may go to a certain doctor somebody in your locality, or send some more information or some pictures if you think so. And if you think the patient needs a physical examination, there's no compulsion to treat him online. He has to come for a physical examination. So that's important. Then also it depends on the type of the consultation. So basically there are two types of the consultation from telemedicine point of view. You have the first time consultation and you have follow-up consultations. So follow-up consultation is easy because you know the patient, you have already seen the patient, and there wouldn't be some document available. The patient might have, you might have them, and that will help you guide the patient better. But if it's the first time consultation, then you have to be a little more careful. You have to get more information on the patient before you are able to make some judgment about the patient's problem. Now, this document also defines what is a first-time consultation. The first ever consultation with an RMP is a first-time consultation. But if the patient has already consulted the doctor for the same problem earlier, and the consultation had happened more than 6 months back, then this will also be considered as a new or a first-time consultation, because 6 months is a long period, things might have changed. And also, if the second consultation was for a different, like the patient has consulted you for a different problem, for a different diagnosis, and now he's come with a different set of complaints, then this is, even though you have seen the patient a few months back, but it's still considered as it. So all these definitions are given in that document, and I think we should, go through that. So second, the last aspect would be the patient management. Now, patient management on teleconsultation could be three things, like education, counseling, and prescription. So all three things can be done, and they are valid. So education is general, because like these days, someone contact you on the phone or on any of these platforms, you can always educate him on the corona and other things, or about his disease, about glaucoma, for instance. And the counseling would be for a specific, which is related to his disease. Like if he has glaucoma and he's not able to come to the hospital, or he's missed some tests, so you can counsel him, okay, look, this test can be done on this date, and you can facilitate that process. And the prescription is, sometimes you might have to give prescribed drugs or some tests online. So that only is to be done when the RMP is sure that he has gathered information and reached that point that he can prescribe a prescription to the patients. And it has to be done in the best interest of the patient. Now, the important thing to note here is that your accountability remains the same. It's the same as if you are seeing the seeing that patient in person. So you can't say that because I saw on internet or on a remote device, so my prescription could be different. It could be so that responsibility is still with you. So you have to be careful before you prescribe online. So you prescribe online, that's valid, but take precautions. It's your responsibility. A registered medical practitioner is entitled to practice telemedicine consultation to other patients anywhere in India. So there are no state borders or limits here. You can do it on pan-India basis, but you can't treat patients or consult patients outside India. So that restriction would be there. Another thing which is coming up in this area is that all RMPs intending to provide online consultation need to complete a mandatory online course within 3 years of its notification. Now, this document is being prepared by the body of the governors, which has replaced MCI Basic. So this is working under the Ministry of Health and Family Welfare Government of India. So they are preparing this document. It is not yet published. So as of now, this clause is not applicable. But once this gets published, then this will come into force. So after that, if you want to do telemedicine, practice telemedicine, or do a remote counseling or consultations, you need to have that online test so that you are eligible for teleconsultation. So this is kind of a safety for the patient's point of view. The other thing is, I said in the beginning, was that the triage for the safety is important. One was the triage for the suitability, whether you want to call the patients or not. And the other is that now the patient wants to come to the hospital, so you have to do the triage for the safety also. So if you have an elderly patient with comorbidities, you can advise those patients to defer the patient, because the hospitals are little high-risk places these days. Also, you can look at the Arogya Setu app and download and update that app. Ask the patient to do it before he comes to the hospital, and also communicate the status. So Arogya Setu app actually does the contact tracing, and it has the location data built into it. And there's also a self-assessment. So it's a kind of a good tool which uses a combined number of technologies to come to a conclusion that the given patient, is it at a high risk or a low risk, or a or a normal risk. So that classification would help you in dealing with this patient later. So this is how, when the patient comes to the hospital, you have to be prepared to deal with that patient. And this is a little video clip that to be prepared. So one thing is that to make sure that your entries is kind of guarded and there's no crowd inside the hospital. And so when the patient comes, all the patients have to be thermally screened. The patient as well as with their attendants should be thermally screened. And if they have fever or their obvious symptoms, they have to be dealt with differently. Sanitize their hands, and if they have, right at the entry. And so you have to basically train your people who are guarding the gates to do these jobs. So if they are not using masks, then give them a mask so that before they enter the triage area, they are already masked and their hands are sanitized. Once that happens, then you have to do a little bit of documentation has to be done. And that documentation basically means that you have to take the declarations, and that's the point of time. We'll also check the Arogya Setu app. So that's what we are doing. So if it shows a green, then he has a kind of passport to go in. But if this shows a red or orange, then he has to be taken to a different area. So make sure your area is thoroughly sanitized periodically every 2 to 3 hours, depending on the the schedule we have set up. And all the patients, they will quickly screen through, and the doctors who are screening, the staff who is screening, they have to be well and take precautions. So they have to use the proper PPE at that stage to minimize transmission to themselves, and also keep the social distancing, leave with one patient at a time. and check the interrogation and the declaration. And once that is done, then, you know, the consent is taken. And once the patient has given his declaration, had given the consent to be treated, then only he or she can go to the hospital. So all these guidelines are actually available now. From here onwards, once the patient has entered, how to deal with these patients subsequently in the clinic, that will be dealt with Dr. Sushmita. So I'll leave you here. And this is just the the guidelines AIOS has given. So Parul already showed you this, and it's worth reading this document, but this is good. This is how kind of we can follow, because this is mandated by the AIOS. So this is a legal document for us, and that can help. And this is another document we should be looking at if you're planning a teleconsultation. So this is given by the Board of Governors, which is in supersession of the Medical Council of India. Like Medical Council of India doesn't exist now, so the Board of Governors decides the matters. And they had a committee on telemedicine practice guidelines, and this was published in 25th of March 2020, so it's quite recent. And this is available at Ministry of Health and Family Welfare website. So you can go, you can search Google, and you'll find this document. And again, you can go through this document to guide you through how to organize telemedicine services and what are the intricacies of that. So I think I'll leave you here. Thank you so much for being there. And if you have any questions now, I think we can take up those questions. I'll stop sharing. Okay, so I'm online, thankfully. Thank you, Dr. Gaurav. I think you made it possible. My internet is turned off.
I would ask the panel members to share any of their ideas or any of their concerns regarding the previous two talks. Sushmita ma'am, what's your experience with the non-contact tonometer aerosolization, or would you suggest only Goldmann applanation tonometer to be used? Because there are lots of conflicting studies about the aerosolization, the microaerosolization. So what's your take on that?
So I think concerning evidence, the earlier studies came from when they isolated the HIV virus in the tears as far back as the early 90s. And that's when the first studies of non-contact came. And that was the scare then, that the tear film does get aerosolized into the atmosphere, because there was a huge thing at that time not to use Goldmann tonometry and to use NCT. And Archives of Ophthalmology took out a landmark paper, 91, because we were all residents at that time, and we were encouraged to read that NCT is not as innocuous as it is turned out to be. So now that the COVID virus has also been isolated in tears, and not just Dr. Rohit Shetty's group, but a couple of others also have comprehensively shown the virus by PCR in the tears. And in 2 out of 30, they were actually there in asymptomatic patients. So again, we would reiterate that the reason for avoiding NCT is that, especially if you're in a closed room, remember that aerosolization is going to go on. And if that air is going to circulate, you have no idea of which asymptomatic patient you are aerosolizing COVID-19 into the room. So at least for now, with the alarming rising trend, I think all glaucoma people would insist on Goldmann applanation tonometry, because the virus is labile and it is killed in 1 minute by a 70% alcohol wipe. So Goldmann is much, much safer if you have to take pressures. So that's the stand of the GSI, and that's the stand of the AIOS. And I think that should be followed for now.
Thank you, ma'am.
So other places, I wonder how are people managing, like Dr. Tully. I mean, Dr. Tully had a few COVID patients actually admitted in his hospital in Kangra. So I think he has actually a first-hand experience probably there dealing those patients. So how was your experience? I mean, how are you managing your services? Are you doing teleconsultation more often, or how often the patients are visiting?
Initially, it was more of patient on telephone only, but for last more than a week, 10 days, a lot of patients are coming. On Saturday, there were around 1,100 patients in our hospital, and nearly 50 patients came to our OPD also. And most of the time, what we're doing is, say, a diagnosed glaucoma patient is coming and we are reassuring. The problem is with the availability of drug most of the time, because barbiturates is not available. So that we are most of the time sorting out on the phone only. We are rescheduling their visits also, reassuring them as those who have got the telephone number and can contact. But patients do trickle in, they come to us. Also, what we're doing is the time pressure we are taking.
Yeah.
Most of the time, we are taking the pressure with the Goldman application tonometer. But yes, we are doing sometime NCT also, some of the non-cooperative patients also. But then it is mandatory that you should have an N95 mask. So all our residents, all our consultants who are seeing the patients, they are having a face shield and 95 gloves. And sometime, if required, we are using NCT also. Because some of the studies they have pointed out, probably it is not that much aerosolization as in some other procedures like syringing and
Sushmita will probably take up this issue, when you speak about this. Yeah, so I think Dr. Sushmita is, is going to discuss it, but I think she just said that the NCT probably is not a good way to.
Not required.
Other methods are better actually than NCT. So
yes, definitely.
I think Dr. Gurustendra was there. Gurustendra, can you see me? How is the scene in Patiala? How are you?
Yeah, I'm fine. Yeah, Patiala is good. Like we don't have too many cases here in Patiala as such, though our hospitals are.
So has your practice changed in some way in Patiala?
One way is I'm seeing less number of patients, actually. So just by appointments, I am seeing the patients. And of course, I'm doing only Goldman's. I'm not doing I never used to do a condition for that, like air puff or any NCT. So I think Goldman is the way to go. That's what I do. I'm using alcohol swabs only to sterilize the tip, which I used to do earlier also, actually. So I've always been using, and still I have seen that prisms do last for more than a year, even with the alcohol wipes. If you're doing about 20 or 25, like capnation tonometers per day. So, and I think Parul was right. It does destroy the prism, but still they last for more than a year each prism, I think. So, I don't know.
There's a question from Dr. Sardana, and they ask that how safe it is to wear gloves and apply sanitizer over it and proceed further. So wearing it once and repeatedly sanitizing it, is it a good practice?
I think the gloves, basically, I think maybe Sushmita will also probably take this issue again, sanitizing other things. I think I have a little, two thoughts about the gloves. On the other hand, they seems to be good because you are using gloves, so you are protecting yourself. But sometimes it gives you a, false confidence. So your hands are protected, but you could be touching everywhere, with those gloves, thinking that you are safe. So that way you might actually spread the virus, different places, thinking that your hands are safe. So gloves are actually keeping your skin safe, but the environment may not be safe unless you use a good hand hygiene. Now here, either you change gloves every time you see a patient or touch any suspected area, which practically is not possible and also financially is not possible. The other thing is to, use hand sanitizer, alcohol, every time. So when you're using gloves, you assume that you're not using any gloves. So you are working with bare hands. The only protection is that your skin will be protected if you're allergic to, some of these sanitizers or alcohol, you're worried about the skin getting damaged. Because you have to repeatedly use these disinfectants on your hands. So I think using glove, I see it more in that context, unless you're planning to change it every time you will see a patient, which is kind of, it doesn't happen. So I think treat gloves as if, use gloves if you want, but treat them as if you are not used any gloves and it's just your bare hand. So you have to sanitize every time, you touch something suspected or see a patient or something. Otherwise, you don't use any gloves and just bare hands, because this virus is susceptible to all the disinfectants. It's not a very resistant virus. So it goes off very quickly and within a very short time. So even if you don't use gloves, it's perfectly okay if you sanitize your hands and you follow a good hand hygiene if you're following. So that's kind of my thinking, but maybe I think we'll definitely ask other panelists to have their view on that.
Dr. Rohit is a part of a very busy practice at the Rotary Eye Hospital, Miranda. What is your current practice pattern? what sort of measures are you taking? You're muted.
I'm sorry. Good evening, everyone. As you rightly said, we have been seeing more number of patients now. So it is touching almost 300 a day. And I have my own share of glaucoma patients. But I have tried to follow the guidelines which were given by the AIOS. So we have stopped the NCT altogether. And for screening purposes, sometimes we do the short stonometry also. But most of my patients, all the suspects and all those regular patients, we are doing the applanation only. Plus, as Dr. Pandav said, yes, we have to take care of ourselves and our staff. So we have very strictly applied this social distancing and the mask and everything. Yes, there is one thing which is slightly disturbing because we can't do the visual fields actually. So many people, they come and they ask for it and we are not sure whether we should continue with that. So right now I have reserved myself. I don't do that. But yes, we have the OCT. So we are kind of following those patients on the OCT. So that is what we are doing. But most of the people, like they're okay with it. That's how we are doing.
I think.
And Parul, you said you apply some sheet on the OCT. What is that? Cling sheet or what?
It's the cling film which we use on the film
in
the kitchen.
Okay.
So we just pull the cling film and put it on the OCT scanning lens. And after each use, you just keep changing the cling film. So that saves the repeated use of alcohol on the scanning lens. Because when you are scanning a patient while doing the OCT, the micro aerosols can also go and stick to the lens. So instead of repeatedly doing that, we put a cling film and also put a transparency sheet along the forehead rest so that there is a barrier between the patient and the technician.
So the signal strength doesn't matter through the cling film and the transparency?
Ma'am, it's hardly a difference of about a single digit. But more or less, the scans have come out decent.
I think the important thing is that
also a part of the AIOS guidelines. So we just followed what they had suggested.
I think important thing is that there's not any wrinkles in the when you.
It has to be really pulled tight.
Yeah, it has to be tight. So if there are wrinkles, then that would induce artifacts.
So what we do is we take a long cling film, tape it up on the plastic part of the device. That way, whatever wrinkles come, they come outside on the plastic part of the device. Yeah. So the point is to take a longer section of the cling film. There was a question regarding how are we changing the frequency of follow-up of the glaucoma patients. So if we were calling them up 3 monthly and it has already been about 3 to 4 months since their last follow-up, how do we plan to go about seeing them? How do we stagger the follow-up from now on? And for those who are actually very concerned about the delay in the follow-up, how do we address that issue?
I think I just did cover it, briefly in the talk, because in a pandemic, it was the peak of the pandemic, then only emergency is that. So other the tests, they can actually wait. Now, if you have a patient who is stable, and if you don't do his visual fields for 3, 4, 5, even 6 months, it's not really going to matter. So basically you had to counsel the patient, okay, look, because of these times, it is safer not to do your test. And because you have been stable, so we don't expect anything to happen, but definitely we'll get back to you as soon as, we can call you back. So you have to prioritize. So if there's a patient on the other hand who has been progressing faster earlier, so that is the patient you'll probably like to adjust somewhere and call, for a follow-up or a field or for whatever, for the test for follow-up basically. So again, you have to prioritize, but then you have to look at the situation in your hospital. If you are able to handle how many patients you are able to handle safely, because safety is primary importance these days when the patient is coming to the hospital. So if you can provide those tests safely, then call. Otherwise, it's okay to defer in these times. So that's kind of accepted, because there are very few patients who actually would be needing an urgent, these tests. Yeah, Dr. Srishti?
Excuse me. Yes, sir. Sorry, sir. I was.
You wanted to say something?
Dr.
Sir,
Pandav.
Yeah.
Yes, sir,
Pandav,
what should be the SOPs for routine surgeries, ocular surgeries? Should we screen all the patient for COVID before surgery?
I think that's a bit of a tricky question. Screening for everybody is ideal, but whether it's practical in your situation or not, that you have to consider. So you have to follow your hospital policy basically on this. So whatever your hospital policy is, that you have to follow, because you can't really go against your hospital policy. But then you have to look at the AIOS guidelines and try to match. Sometimes there could be a little discrepancy, but try to find the the closest path that is to the guidelines. So whatever is the closest, we have to do that. Yeah.
Good, Sithinder, you were saying something?
Yeah, I just want to ask Dr. Pandav, how much is the number of patients, like what percentage of patients we're getting now as compared to earlier?
No,
In the clinic.
like we used to see how many patients. If you look at the eye center as a whole, we'll see like 1,500 on an average on any day. So that varies from 1,000 to 2,000, but on average, looking at 1,500 patients. And now we probably see 250, 300 patients. So, so that's the drop. Because all these patients, we are not seeing any walk-in patient as such. I think Dr. Rajiv had a problem because the government announced that on this particular day, everything opens up. And when the government says that things are open, people believe that everything is open, the hospitals are open, the virus has disappeared, and overnight everything is fine. So, that message doesn't go to the public, probably in an understandable manner. But I think, so that's why whenever there's an announcement of this nature, more patients come to the hospital. So we have also seen that spurt, but people realize very quickly, in a day or so that, okay, everything is not open and there are restrictions still on. So we do see some spurts, but I think the numbers are very much less than what we used to see earlier. The maximum number of the teleconsultation calls or the visit we have are from number one is the retina specialty. So the retina people, they see in the maximum as of now. And number two is the glaucoma patients. So these are the two categories of patients who are actually calling more frequently, and they're also visiting a little more frequently as compared to other specialties like oculoplastics, even cornea cataracts. They are not coming these days because they don't want to get operated. It's a elective surgery. Refractive surgery is also in our institution, at least it's not on yet. The only other exception is some, the malignancies. The children is another exception. More children are actually coming to us because they have no other place to go. So pediatric glaucoma is coming and other pediatric related complications, they are coming. So we have the retina, we have glaucoma, and we have children. I think these are the three major users of our teleconsultation services and also the physical presence in the hospital.
So we have a few more questions regarding disinfection of the things that we use in the OPD, but I think we'll take them up after Professor.
Yeah, I think we'll take that after Dr.
Yes, and with this, I invite Professor Sushmita Kaushik for her enlightening talk on making OPD consultations safe for patients and ourselves. Professor Kaushik.
So can you see my slides now?
Yes. Yeah, we can see your slide.
And visible also?
Yes.
Hopefully. Okay. So this is a continuation of what Professor Pandav said, and what I'm going to sort of illustrate is not go through guidelines, but we've tried to just show you what we do. And this is what we think, like Parul said, each of us has to make our own SOPs. So this is what we thought would work for us. So my slide's not going further. All right. So why do we need a safe practice? We all know that. I mean, this is yesterday's data in the country. It's all around us. It's rising alarmingly. It's highly infectious. But the problem is the effect is unpredictable. And the only thing that really we can do is break the chain. And that's going to be the main thing of my talk. Of how
Sushmita,
we can...
I can't hear you.
Okay. Am I audible?
I don't know if others can hear you. I don't know.
Yeah, we could.
You're audible, ma'am.
Yeah.
I'm audible.
Just if you don't mind, just my request, when the speaker is talking, other people should mute their mics and also switch off the video, because that helps with the transmission.
Right. Dr. Gursitinder, is that audible now? Hello, is that audible now?
Yes,
Very
ma'am.
audible, ma'am.
Yeah. Okay. I'll carry on. All right.
It's
So
audible now. Audible.
yeah, it is okay. So just a bit about the COVID. So we know what we're dealing with. It's a family of coronavirus, and at least 7 have been known to cause human infection. And the one that we're dealing with now is the SARS-CoV-2, which is a lipophilic virus, and it's already affected 200 countries. So we know that. And the principle is severe acute respiratory symptoms and fever, but remember, no organ is spared. So it spreads mainly via respiratory route, but what is important for us, as Dr. Parul just said, that its conjunctivitis is not only one of the spectrum of its presentation, but it's also been demonstrated in tears in asymptomatic individuals, which is what is our major concern. So the onus is on us to prevent the spread to as well as from the patients in our clinics, both ways. So I'm going to talk of disinfection and sterilization. A quick recap that disinfection means killing microorganisms except spores, and sterilization is killing all microorganisms. So for our clinics, we need to be killing the microorganisms, including the viruses. In our OPD and clinics, we need a proper disinfection and preventive measures for checking the spread. And I'm going to be talking, there are lots and lots of them which are in literature and which are effective, but I'm going to talk to you about the 2 that we are using in our center. And the 2 disinfectants which are used most frequently is alcohol and sodium hypochlorite, because they're easily available and cheap. So the common disinfectants are, of course, alcohol. The mode of action is denaturation of all proteins of microorganisms, chiefly found in hand sanitizers as well as isopropyl alcohol wipes. So the microbicidal activity of ethyl alcohol, 60 to 80%, it's potent virucidal, inactivates all of the lipophilic and many hydrophilic as well, in which adenovirus is the most problematic for us. But important nowadays, corona, herpes, and vaccinia are all killed with ethyl alcohol. Isopropyl alcohol, 70% on the other hand, are active against the lipophilic like corona, but remember, they are not active against the non-lipophilic ones like adenovirus. So even though nowadays we are concerned with COVID-19, remember 70% isopropyl alcohol is not. So we've actually shifted to absolute alcohol or ethyl alcohol in our clinics, which is actually easier to get. So the common disinfectants for surface disinfection are chloride disinfectants. So the mode of action is because of the toxic effect of undissociated hypochlorous acid, or HOCl. So the hypochlorites could be available in 2 forms: liquid, which is sodium hypochlorite, which is what we hear about, and solid is calcium hypochlorite. Now this is a SAC from our OT. So we went up and actually asked them, what is it that you use for carbolization? So this is cheaper, but it's also less purified, but for routine everyday carbolization, this is all right. So this is called bleaching powder grade 1, and this is calcium hypochlorite, which is made into a 1% hypochlorite solution, and this is a powder. But what we are used to in the clinics and for our slit lamps and surfaces, as well as the tonometer tips, is sodium hypochlorite. We'll look at that a little more. And this is 4% available in the solution, which is a readily available 4-liter jerry can. Now, the household bleach that we use, Clorox or Lysol or whatever, has about 5.25 to 6.15%. Household bleach can also be diluted and used as a common disinfectant in the clinic. This is hospital grade, but even a household bleach is okay. So the microbicidal activity is bactericidal, fungicidal, sporicidal at these percentages. Important for us, virucidal at 0.02 to 0.05. So I'm just going to spend a little bit, and this is of course effective against all viruses. So if you go to the American Academy guidelines, and there's a little bit of incongruity in these guidelines of percentages. So there is a little bit of a confusion there. If you go to the AAO site, they say 1 in 10% or 1 in 10 of household bleach, from where the AIOS has got a percentage of 0.5%. So 1 in 10 of 5% would be 0.5%. But then remember, they are virucidal at much less. So LV Prasad Eye Institute, when they gave their webinar on disinfection, they said 0.1%. So we understand now that 0.1% is as effective for the corona and for most other organisms as well. So 0.1% is lesser corrosive. it prolongs the life of the tonometer tip, and it is less corrosive to the metal around it. So we are now using 0.1% for the tonometer tips and 1% for surface disinfection of all the others. And we'll just go through what we do. So the outline of our safe practice is now our new normal. So I'll go through the clinical environment for examining patients, the protective attire for all personnel, some suggestions that we do, a patient flow and management once they've come in through the triage, and procedures especially related to glaucoma. So the environment, most importantly, is you need proper air circulation. You don't want that same bit of air to be circulating all around your clinic. So all doors are to be open. So the days of a closed chamber, AC, quiet environment are gone. All doors open, fans running for proper circulation. And this also ensures no touching of door handles and latches repeatedly if they're always open. The guidelines for air conditioning is said that there ideally should be a fresh air in, cooled, and exhaust component. It is possible if it is a one window AC or if it's a split AC, but for large buildings like the Advanced Eye Center with a common AHU, this gets to be very difficult. So I confess that right now we are not abiding by, because it has just been absolutely impossible to have exhausts in every room in the center. Having said that, we disinfect the clinic every morning. The hospital attendant is in a glove and mask. We use 1% sodium hypochlorite, and all surfaces are cleaned and mopped thoroughly before we start. So this is how the environment is cleaned in the morning before we start. And I'll just give you a little video on this. So this is our clinic. This is the sodium hypochlorite that we use. Thank you to Mr. Niranjan. He's our partner in crime throughout. So he works with us in the clinic. So 4% means 1 in 4 makes it 1%. So he uses 250 ml of the sodium hypochlorite, and he adds 750 ml of water. Basically a 1:3 concentration to dilute it 4 times and make a 4% hypochlorite, a 1% hypochlorite. So this is how he's measuring it out. He does this every morning at 7:30 before we come in. So once he's measured that out, he pours that into the beaker. Now remember, this is used for everything. All surfaces, doors, handles, windows, tables, and especially chairs and their handles. So now that this beaker is ready for him to start his carbolization, now this 1%, he uses a 10 cc syringe. He takes 1 ml into this 10 cc syringe and makes it up to 10 ml, and that gives us our 0.1% for our tonometer tip. The prisms are soaked in this for not more than 4 minutes. More than that would corrode the tip and would damage the cornea. So that's the standard guideline. So that's why we dilute this 1% that we formed 10 times. So that's 1 ml. And now he's diluting it up to 10 ml in a 10 ml syringe. And then once he puts that into a small box, all the tonometer tips of the clinic are put into that and soaked. And he is told that this is the most important part of the glaucoma clinic procedure. So he puts that exactly 4 minutes. And once the 4 minutes are done, you can see the tip is soaked in it. All the tips go into this 10 ml. And then once it's out, it is thoroughly rinsed because we don't want any residues of the hypochlorite on it. And this is done once before starting and once at the end. So while Niranjan is doing that, the rest of the staff is cleaning the entire, and this happens every morning. All surfaces are cleaned well with 1% sodium hypochlorite to disinfect as much as we can. Door handles are given a lot of importance because everybody has somehow a habit of hanging on to the door. So that's how our clinic is prepared. And then the next thing is no crowds in the waiting area. Now you would say easier said than done. And pre-COVID, we would have said easier said than done also. But once we put our heads to it, it is possible. So you can see the waiting area chairs are taped. This is the area outside the lens clinic, the glaucoma clinic, and the biometry room. Usually it used to be chock-a-block, but now the patients sit in an outside waiting area, which is airy, which is large, and there is no crowding right outside the clinic. And of course, there is social distancing, and all patients, remember, have come with a mask, and they have been triaged already before coming to us. So the next is the attire. This is a dear friend of mine who's allowed me to use her picture. So this is the hospital gown. So starting with the security guards or attendants at the gate and triage team, they are the first contact, the front line, and they have to be protected completely. So they have masks, they have face shield, they have gown, and they have gloves, because they are going to be handling the patient's cards the most and the first. Then the patient has to be in a mask. No patient walks in without a mask. The hospital attendants and the registration counter, once a patient goes in, again have to be in mask and gloves. And the doctor, now you see her, she's in an N95 mask. There are gown or scrubs, that is up to you. But it's a good idea to cover your own clothes and not carry the same clothes home. So I personally use OT scrubs whenever I go to the clinic. But some of us use a lab coat, some of us use an OT gown. So whatever you feel comfortable in. This is the battle gear that we've been provided. It's actually a studs helmet. It is impossible to do slit lamp biomicroscopy with it. But for me personally, it's very useful because I tend to go very close to examine children. So when you have to go close, then this is a good thing to have. And of course, I take it out when I have to use the slit lamp. This is the N95 mask, and you can use goggles for protecting your eyes. And a cap is important because the virus is known by static to stick to hair. And I'm more concerned with taking that head of virus home than anything else. We all have a slit lamp shield between us and the patient. And the gloves, as Professor Pandav said, is optional. But whether you use gloves or not, the important thing is that you have to clean gloved or ungloved hand between every patient. So once this is done and we are all attired and ready, so this is a short video showing the patient entry and the examination. So this is really the 2 rooms of our clinic, and then this has already been disinfected. This is the place outside with some posters. Now I'm going to pause here a little bit because, sorry. So this is a box. I mean, you can have it much better, of course, but this box is, now this patient is carrying a self-declaration form. This is what Dr. Parul alluded to briefly. So this form is available on the AIOS website. We have condensed 2 forms into one, so that is 1 piece of paper. And we have a Hindi and Punjabi version as well. Basically, it's a self-declaration form that you have not come in contact with a COVID patient, you have not had travel to a COVID positive area, you do not come from a COVID containment zone. So that is declared and signed. And importantly for us, there is a consent below that which says, I know I am visiting the hospital in a COVID pandemic. I understand that I have a risk of getting infections, but I also understand that this risk is mine and I'm not holding the hospital responsible. I think with the exploding pandemic that is happening, this little piece of paper is going to be important for us in the times to come. So what is done is the patient carries this self-declaration form into the clinic. Every clinic outside has some sort of mechanism to take it. It's dropped into this box. For 24 hours, it is let to air dry. The HA does not hold it or handle it before that. Next morning, all of them have, at least in our clinic, a GL number or a fundus clinic number or a CO number or whatever that may be, and then it is filed. So this we have in our hospital records that on this date, the patient came with full consent and then we examine them. So this is what he does. He comes, he signs, and sorry. Right, so this is what we have inside. So he signs, he puts it into the box, and then his hands are, he's told to put his pen inside, and then the hands are sanitized. So the little boy jumps because he doesn't know what it is, and then he also gets his sanitizer. So once they are sanitized well. Now the new normal is, this is Dr. Gaurav who's really worked to make all this possible. So the new normal here is we would normally have the patient come straight onto the slit lamp because we would have so many patients waiting and we have no time to talk to them. So the new normal for us is they don't come on the slit lamp. All the talking and chatting that we need to do is at least a meter away. So the patient sits away from us and does not come to the slit lamp unless we want to examine them. So you see, Dr. Gaurav is talking to the patient, asking him what the problem was, why he's come and what, but all that is while they are waiting. And only when he has seen it, he has seen what the card is, what the problem is that he's going to tell the patient to sit. So now that he understands what to do, and then the boy comes. So he's a little boy with pediatric glaucoma. So Dr. Gaurav will also, I think, be able to do an applanation tonometry on him. So once it is cleaned and everything is done, so he cleans the prism as well, and then the patient is examined just as much as you need to be examined. You can see there's a slit lamp shield here. So this is the shield between the patient and the doctor. And once it is done, it is important to clean the applanation tip immediately and then go on so that there is time between the next patient for this to be dried. Regarding the 90D and the Goldman and the gonioscope, again, to avoid it, this is our routine practice, so we are carrying on with it. We don't use 70% alcohol because we see that the glue comes off and it gets to be a little loose. So we've always used soap and water, and we continue using that at the end of every examination. The gonioscope and the 90D lens, as was our usual practice, is cleaned with soap and water thoroughly before being used in the next patient. So in between, that's another important thing. Every 2 hours is what is recommended. It can go up to 2.5 hours maybe, but every 2 hours there's a break. The clinic is given a breathing time. All surfaces are disinfected with 1% sodium hypochlorite again, the same solution. Now that solution is reconstituted once and it lasts for just 1 day. And every day morning we reconstitute it again. Give the clinic a breathing time and then we start all over again. Diagnostic tests, we've spoken a little about it. In this day and age, it's really not mandatory. Glaucoma is pretty much a clinical diagnosis and a clinical follow-up, and a vast majority of our patients can be seen clinically, and the test may be deferred for 3 to 6 months. So what we are doing is, for now, we are avoiding the visual field. And if imperative, then we carefully follow the manufacturer's instructions for cleaning the bowl after every use. But remember that responsibility of cleaning, they themselves say don't do it too often. So they also, I'm sure, didn't envisage this pandemic happening. The matrix which we have, which is FDT, so that is something like the OCT for acquisition of images. There's no bowl. So it gives reasonable visual fields, and if imperative, we are using that. Structural tests may be done, if not done for a while, because it gives you some idea. But our practice now is, since we have the records, if the fields have been stable for some time and the pressures are within target, we safely say that, look, everything looks all right now. Another 3 to 6 months is not going to matter, and we defer doing the fields and the other tests. Ultrasound and UBM is a little more tricky. Especially the UBM is likely to be aerosol generating. So please be careful, and it's safer to wear a face shield or goggles while doing these investigations. Of course, sometimes it is required and it needs to be done, but just be very careful when you're doing it. So when we wind up at the end of the day, the last thing we do is that tonometer prisms are dipped in 0.1% sodium hypochlorite again for 4 minutes. Then they are washed and they're kept back in their holders. All lenses are washed with soap and water and dried. All surfaces are cleaned again. We don't use the UV light, but there are some hospitals which have started using ultraviolet light. If you do use them, then it's recommended to switch on overnight and switch off an hour before coming in to run the clinic again. So thank you. That's about it for disinfection and the patient flow. Stay safe and break the chain. I think I'll stop sharing now.
Thank you, Sushmita ma'am, for such a wonderful talk. The videos were really enlightening. And I think we can now take up the questions that have come to us. The first question is by Dr. Raminder, and she asks that are disposable tonometer prisms helpful? So do we use disposable prisms at PGI?
No, we don't use them, but it's a great idea to have them if we can. They're called tono-safe, and if you have a set of tono-safe, it's very good. All you need to do is put your prism into it like that, and then fix it on, and then you can just, it's just a cover, and the reliability is as good. So if you have the tono-safe, that's the ideal thing to use nowadays.
Another question is that somebody wants to clarify on the use of the FFP3 masks in men with beard. Is it recommended to use FFP masks? So anybody from the panel would like to say something about that? Actually, FFP3 masks are nothing but another version of N95 only. So FFP is nothing but a European way of branding the masks, and they are as safe as N95. Yes, as regards the beard does not help in formation of the seal. So when you are doing a procedure which warrants an N95 sort of a seal, I think the FFP3 masks should not be used. Since the US is running out of the N95s, we are moving to using KN95 from China and the FFP3 from Europe, which is being imported from there. So it's just a varied terminology. Essentially, all of them are taking care of 95% of the particulate matter that we are releasing into the environment.
The issue was with because the beard doesn't let it become a watertight.
It doesn't form because of the hair.
You have to be careful, yes.
So anybody from the panel would like to share or ask any concerns regarding the disinfection protocols that Madam has very beautifully covered with the videos?
Hello, can you hear me?
Yes.
Yeah.
My audio is very poor, so I'm just holding my phone to the ear. I hope you can hear. The only way you can do, is you can tie a, tie on the beard, that thati thing, if you understand that.
Mm-hmm.
So it's a cloth which is tied from the beard to the head. So if you tie that cloth tightly, so it can ensure a good seal.
Okay. All right, so there's a way out. I think that should be known. I'm sure it is known.
I think that's the only way the Sikhs are trying, even in Europe or America also. So they're tying a thati under the mask, that like thati, I think a lot of you might have seen Sikhs wearing it, or, setting the beard. So you tie it, it's a piece of cloth which is tied to the like beard and wrapped around the beard and tied on the head top. So it really, it creates a good seal.
Okay. Dr. Loya asked that if we are using a face shield or a face visor, then is using a 3-ply mask not enough? Would like to know the panel's take on this.
Go ahead.
Okay, so one suggestion, if you don't have an N95, basically the N95 has a seal. So the other thing that people do in the OR, because sometimes it gets very difficult to operate with that, is if you just tape the 3-ply mask all around. So tape it down and then blow it out, and actually you can get a very good seal. So that's a to-do thing if you don't have an N95. The idea is to seal out the air coming out, except that even that gets suffocating at times, but that's the alternative, a 3-ply.
Yeah, I think the associated question was that if you are using a face shield, is it still required? So I think it's still required because the shield is going to protect you with the direct, because you are coming very close to the patient when you're doing slit examination, because distance is very small. So the direct, the droplet, the communication would be there. So that will be stopped by the shield. But these micro droplets, they can come around the shield by air currents. So because you're breathing, so there are air currents being generated, and that can take some of these particles around the shield to your breathing space. So that's where the mask is still important. So whatever mask you use, as Dr. Sushmita said, like it has to be sealed, it has to be airtight. So when you're doing on the slit lamp, make sure that you kind of seal it with the tape if it's not a N95 mic. The surgical mask is as good, but it has to be kind of properly sealed.
Dr. Sunil, what are the precautions that you're following at your practice? What is your current scenario at your clinic? You're muted, please. Dr. Sunil, you're not audible.
Rohit, maybe you can unmute him.
Sir is already unmuted.
But we're not able to hear him.
Okay, so till we get the Sunil, maybe, Ujjwala is there, how is your practice changing now with the COVID?
Well,
how are you managing your disinfection and how are you managing your patients?
Pretty much what has been discussed. We, in my clinic, all of us, as soon as we come, we change into the OT attire so that we don't wear our own clothes that we bring from home, so that we don't carry it back home. And and it's all cap mask, and the girls are using the 3-ply. I use the N95. And I just wanted to know from you, like, are you using goggles too? Because I find it difficult to do the slit lamp examination with them on. So, or are you using any particular type of goggle which works better? I don't know.
Goggles will be useful, I guess, but because I'm using glasses, so I find it a little awkward to have 2 glasses on. But having said that, I think because the goggles they're bigger in size and they definitely give you more protection. So I think it will probably take a little getting used to it, but this should be okay. I think Sushmita, you were using.
No, we're not using goggles. And in fact, I've told my SRs to get plain glasses as well. At least they can use that. Some protection for the eye, if not a full thing. So I've suggested get some plain non-pard chashma while you're doing it, because.
And I use the Bacillol spray to disinfect the prism.
So, ma'am, what does Bacillol have? Also 0.1%?
It has ethanol, isopropyl alcohol. It's a combination.
Okay.
So it's quite good. And it's in a very user-friendly way. So, you just have to use a very minimum maneuver to just disinfect the thing. So I just use that. And I don't know, the practice has changed because, like, ever since we've opened, which has been about a month, I can't tell you how many hypermature cataracts I'm getting. I mean, I don't know whether it is because the government hospitals are not working or, seeing patients because they're committed to other things. So I don't know if that is the reason, but I've had 2 phacomorphic glaucomas in this 1 month, and so many of them with shallow chambers, hypermature intumescent cataracts. I mean, which, just to give you a perspective, in the last 2 weeks, I have operated on 6 hypermature cataracts, so which is quite unusual in my practice.
Did you get them screened for coronavirus?
Yes, that's another thing. I had put it on our group also, because in the medical college, they're insisting on screening every patient that goes to the theater. But that facility is not available for the people in the private setup or the patients who come to the private setup. So I don't understand that very much. But so we don't have that thing. And I was seeing the guidelines and I put it up for people to comment on as well. And I was told that, if it is a cataract like that, then, and there's nowhere for them to go. So then, I just, we screen them for other ways, like, and since we are lucky that Shimla is still in the green zone. So, it's like, right now, till now, it was okay, but now I'm going to be probably getting more conservative.
As per the AIOS, it's not mandatory, only if the patients are coming from an
exactly. But I feel this 2-prong thing is probably needs to be addressed, because I think all medical professionals, whether it's in the private setup or government setup or whatever, should have the same sort of parameters to, do their cases.
Ma'am, in fact, we're on the other side because ICMR has not mandated it. So there is no ICMR guideline. And because the ICMR guideline does not say pre-operative or pre-admission testing, PGI's virology department is an ICMR lab, so we will not get it done.
Exactly.
So even if you want to, unless your infectious disease person or your nodal officer has said that it's a suspicion of COVID and he needs to be tested, because our screening is completely clinical. So even if we said somebody in the red zone or orange zone that the person has come and clinically there's nothing, there is no way that we can get them tested in the government sector. We can ask for a private test if we want, but it won't be done. So the problem is that the government has not mandated it. So whether private or public sector, if that's not a mandate, the government labs will not do it.
Yeah, but they're doing it for all government patients in the government theaters or whatever in the government setup. But having said that, I must say that yesterday I had a patient who'd come from an orange zone, and then I spoke to the nodal officer, and he agreed to first test that patient for us. So,
So, ma'am, the other thing that I've just had one from Palampur. I don't know whether Rohit you sent it. So the baby came 8-month-olds. So they came from an orange zone. So we sent for screening. Of course, clinically they were screened, and the pediatrician sent back and said that there are no symptoms suggestive of COVID. Now, I'm so scared because intubation in asymptomatic patients have been associated with mortality. So my babies need to be intubated. So one way out, which I have devised, and maybe it'll be useful, is that a 2-week quarantine completely. So I tell the parents this baby is not going to come out of the house. And even if you tell the parents that there's a risk to the life, if he is contracted and he's asymptomatic, they understand. The rationale of that is within the next, even if he has had it in the last 3-4 days, within the next 2 weeks, he should be symptomatic and then will be tested and will be treated. And if in the next 2 weeks he does not develop any symptoms, I am safer to take that baby up without a test. So now people who are coming from orange or red zones, because there's no testing possible, I'm quarantining all of them. So I've operated 6 babies so far. I haven't had a problem. This was the first, which was orange, and this is what I'm going to do.
Dr. Sunil, are you back on? Can you please try unmuting? Unfortunately, he's not audible.
I think I can see some questions there. Are there some questions waiting to be answered?
We have covered up all the questions.
Right. I have a comment to make. See, even RT-PCR, that is going to pick up only 70 to 80%. So even if you're going to do it, it is not that you are going to pick up each one of them. So many of them are going to be missed out. They are negative initially, maybe after a few days come positive. So we are also not doing all the patients. We are operating on whatever emergency cases. We are not doing a COVID test preoperatively, unless it's a suspicious case. Otherwise, we are not doing.
Yeah, I think there's no foolproof way. Actually, the idea is just to minimize the risk. I mean,
that's true. That's
100%. But whatever is available, you have to use your resources to minimize the risk for yourself and also for your patients. So wherever possible, if you could do testing, if it is possible, allowed by your institution, definitely, I think that's a better way of doing it. Otherwise, you have to go by the best, the recommendations that you do. And of course, you have to improvise, depending on your situation as well. So what the idea is to make it as safer as possible for patient as well as for yourself, because both parties need to be safe from this virus.
So Dr. Rajiv, my greatest worry is in this non-testing business for hospital admitted patients, for admissions, is mixing them. I mean, this person might be asymptomatic and young and healthy and nothing will happen. But if he's on a bed next to an 80-year-old diabetic Mataji, now that's the thing that I'm scared about, which is why I wish somebody would, take that up. That's my only concern. Otherwise, it's okay.
But they have this facility. They have a nodal officer, and if he recommends, you can get it done. See, for any patient, that way, in our institution, they're doing it. They say, once you recommend it, we'll do it.
Yeah, so I think there is some mechanism basically you have to justify because the resources are to be used more often. Yeah, because the resources have to be used optimally, and in the coming days you'll need more and more resources. So I think it makes sense that you utilize them to the most economically, and when you spend them wisely basically because the resources are limited. So I think that limitation would remain. So
Dr. Pandav, I think. Yeah, Dr. Pandav, I think even the ICMR lab is there in Shimla, and even Tanda is ICMR lab, so they're doing it. So I think you can also try to get it done through them. So
yeah, because our policies are getting revised. Actually, our policy is getting updated very frequently, I would say. Because we have gone through several versions of even the PPE used in the hospital. We had gone to six, 7 versions already. So it's getting, kind of revised from time to time. So I'm sure the things, would change.
Can I say something, sir? We have started following we have about 20 to 25 surgeries every day now, but we are not sending them for COVID testing, all of them. But we have reserved that thing to the procedures which could be potentially aerosol generating, like doing our pediatric cataracts and other surgeries, which will need intubation and all that. So as far as cataract is concerned, we try to minimize the stay of the patient. We usually operate them on the same day, and we encourage them to go back home rather than staying. And in the ward also, we have kind of spaced out the beds so that they are at least 3 meters or 4 meters apart. And moreover, it is mandatory to wear a mask all the time. So that I think makes a lot of difference. Yes, in the cataract surgery also, where there was a lot of talk about this phaco machine creating aerosols. So we are trying to avoid that. We're doing more of SICS. And moreover, even like for personally, like I'm wearing this eye shield, and I'm motivating all my other staff members also to cover themselves well. And even a forceful injection of sometimes you want to irrigate the eye or something. If you can avoid that, that is indirectly going to reduce the kind of droplet formation. So this is how I think these are the practical things which we can do to avoid all these things. Yeah, and reserve the COVID testing to only to the aerosol generating procedures.
So it has been suggested to, rather than irrigate the surgical field, to use a lot of viscoelastic instead of irrigating.
Yes, exactly.
We have overshot our time by about half an hour. And with that, I would like to request Professor Pandav for his closing remarks. And it has been a very enlightening session. So Professor Pandav, to please conclude.
Yeah, thank you, Parul, for moderating the session, and thank you all the panelists and the speakers for for the enthusiastic discussion. I think we had a good discussion over this. My battery is running low; it could close anytime. So I think I thank you all, and especially the AICE for making this the hosting this video conferencing through their website, because it's very important. Room free is available, but they make it more secure because they're concerned with the security issues. So I think they have taken all those precautions. That's why we thought we'll use that platform. And thank you, Rohit, Prashur, for giving us this platform and helping us. And I'm sure we'll see each other, more often on this platform or otherwise. I think the COVID is going to stay here, and we need to discuss it more. We had a very useful interaction on how to go about, telemedicine and how to do the sanitization, how to make basically things safer for ourselves and for the community in general. And I think we need to discuss more about it. So with this, I thank you all very much, everyone, and thank you, Paul, for moderating the session. Thank you, everyone. Thanks.
Thank you.
Good evening, everyone.
Thanks a lot.